document and have them all on one sheet. There may not be a ton of it, but even if it's like, you know, a page full of stuff, it's kind of extra things you need to know or go look for maybe in your textbook too. So some of these things we talked about, some we did not. So the one thing for pulmonary function testing that I want you to know for your test is that you can't just do them in a regular visit with a primary care provider. What do you have to do for that? You have to go to a specialist, right? What is that specialist called? A pulmonologist, right? So a specialty just in lungs. And when they do this pulmonology appointment, there's one value, there are others, don't think this is the only one, but there is one value that I want you to know for your test. Remember what it was? With an F. Force, expiratory, volume, and then how many seconds? 1 second, okay? So on your test, I might say something on the lines of, the FEV1 is 60% of expected. So what did I say was normal, or what was a good number? 80 or higher, so you can say anything over 80%. That just means that whatever their normal is, or whatever they're supposed to be at, based on their lung anatomy and problems, that 80% of what they normally would do. So that's pretty good, okay? So anything less than 80, you would say, oh, that's not very good. There might be some, you know, asthma, COPD, lung issues there. So on the test, that's all I'm gonna ask about pulmonary function test. So if you see that number, that's what that means. VQ scanning, we talked about that last year just a little bit, but we can put, and really this can be done anywhere, but if we wanna know how your alveoli are actually ventilating, so we can get a good idea by your ADGs, your pulse oximeter, your pulmonary function test, but sometimes they have to inject kind of a dye to light up your alveoli to see which alveoli aren't doing anything, right? So this is how they determine if you need like a lung transplant, where is the most bothersome part of your lung. So if they put this dye in there, they will see the actual capillaries fill with oxygen and fill with blood, and then if there's poor perfusion in one area, they can pinpoint that with VQ scanning or VQ matching. So if you ever see VQ scanning, it's looking at the alveoli to see if you actually are ventilating in your lungs, okay? And then what percentage of COPD, or asthma for that matter, is tied to a genetic component with alpha antitrypsin? What did I say was the percentage?
5.
5, okay? So these are the people, there's 5%, which actually is not that much. So I don't want you to think that, oh, if mom has COPD, I'm destined to have it. Maybe you had it because you were exposed to secondhand smoke your entire life. Does that make a little sense too, where smoke is primarily gonna be what you have as a risk factor, and even though mom or dad maybe doesn't have your gene that passes on to you, you were exposed initially from birth, and that's why you probably have the exposure, okay? But smoke is still a primary risk factor in like 80% up to 90 of COPD cases. And then ABGs. This test is not really determining what ABGs mean per se, but you have to kind of know some normal values because I'm going to give you some ABGs that are going to confirm a diagnosis of COPD. So what are the two I'll probably ask? AO2, and then you'll see this kind of interchange in different places, but you can have PaCO2 or PCO2. This is the same thing. Don't think that they're different, okay? So sometimes they put that little A there, it's the same as just PCO2. And that normal, 80 to 100 is where we want to be for anyone that is not having a disease of the lungs, we want. And then CO2, 35 to 45. Again, this was on our quiz, but these are just numbers that you're gonna have to just kind of know going forward with this test, and then when it comes to ABG analysis, we'll figure out how to really interpret ABGs. That's the next test, like the 2 tests. So what would be something consistent with a patient that has COPD? They'll have lower PaO2, and higher CO2, okay? I don't want you to get too married to this number. Even though we do call them 50-50ers, doesn't mean every person with COPD has a 50-50. That is not the case. Now, end stage or stage 4 COPDers, yes, they probably do, okay? But what if they're in stage 1 where they're in the beginning stages? They may not be this classic 50-50er. They might have a PaO2 of 72, and then their CO2 is like 47, okay? So still, what the information is telling you, it's a low PaO2 and a high CO2, okay? It's still at that realm, but it's not quite that number 50-50, okay? So I just want want you to remember that it's not always gonna be this perfect 50-50. But if you ever see someone at clinical, you'll probably see that really bad. Okay, and then we kind of talked about those other ones, but CDC I wanna talk about, if you look below, the word polycythemia. Put that in your vocabulary for COPD, okay? Polycythemia is when your body has to kind of overcompensate, because remember, oxygen is carried how in the body? Hemoglobin, right? So it overcompensates and your kidneys actually start to produce erythropoietin. What is that? Red blood cells, right? So it's overcompensating for that. So you'll see these kind of false highs with your red blood cell, your hematocrit, your hemoglobin. Because remember, those three are married. They're all gonna be high together or they're all gonna be low together. Red blood cells, H and H, okay? So if those are all high, and I'm talking like a hemoglobin of 20 or hematocrit of 60%, pretty high, you're gonna suspect that maybe they have some more advanced COPD, okay? Again, this isn't gonna happen in the stage 1, but more those advanced cases. Okay? And then on your test, what am I gonna say about a chest x-ray with COPD? I'm not gonna have a COPD patient on an x-ray and you have to interpret it. That's not your scope as a nurse. But as a nurse, is it your job to look at the bottom of a report and look to see what was in that chest x-ray? Because a radiologist looked at it. Yes. So what are some key things you're looking for on the test? So flattened diaphragm, and I heard Eric say it. Or did you say flattened too? What did you say? Okay, so is it gonna say barrel chest? No, we would probably use those terms as a nurse to say, oh, they have barrel chest, and that's something from the exterior, but you're gonna look at the hyperinflation, right, of the alveoli. So hyperinflation of alveoli, which will cause a barrel chest, and then the flattened diaphragm, okay? Where's Abby? You knew I was gonna bring you up today, right? You're like, well, I'll remember that. What did I tell you yesterday at clinical? I said something about an x-ray. We were looking at x-rays together, and she goes, well, how would we know it's COPD? It was based on, this guy was normal, he didn't have COPD. How would I know it was hyperinflated? What did I say? Okay, so if you look at an x-ray, we'll pull one up here. So in a normal chest x-ray, look at our diaphragm. Where's our diaphragm? Let's start there. It's curved, right? It looks like a C, okay? So if you think about this, if you have hyperinflated alveoli, they're gonna be really stiff or they just stay hyperinflated and they just sit there. So normally when we take a deep breath in, your diaphragm actually goes down so it can allow air to get in your alveoli. So what does the diaphragm do when you exhale? It goes back up to push the alveoli out so you can push out. So that's why we're talking about like abdominal breathing, pursed lip breathing. It really focuses on keeping your diaphragm pushed up when you exhale. Because remember when we went like this? Inhale, your lungs get bigger. They're inflating your alveoli. When you exhale, your alveoli are supposed to clamp down. Your diaphragm's gonna help with that process to push them down, okay? So you'll see this literally, it'll be like flat. It won't be this nice curve, okay? Another thing is counting ribs. Usually in a regular person, when they take an x-ray, there's between 8, maybe 10 ribs if they have a really deep breath, okay? In a person with COPD, you're gonna count about 12 ribs, okay? So you know that based on the person has a lot more trapped air inside of their lungs. So you see more ribs. I would never put this on a test for like counting ribs, like that's not your scope. That'd be like rad tech program, okay? However, I'm gonna put the hyperinflation and the flattened diaphragm. But as a nurse, you're gonna start looking at these and you can see them. Okay, so I just wanted to kind of hit on some of those labs so we understand what those mean. Diagnostics. So you can have a transplant, that is possible with a lung transplant. The nice thing about lung transplants is that even though you have 2 bad lungs, even one is gonna do a lot of good. So you can function with 1 good lung and 1 bad lung, but there are cases where they do bilateral lung transfers. So what would be something as any transplant, whenever you see transplant on your boards, what are things that are going through your head as to who qualifies and who doesn't? Younger, and I mean like less than 65 usually, right? We don't need 20-year-olds. Less than 65. Okay, so I like the word healthy just because we have to think about, these people are still sick and they have a transplant coming. However, they can't be so ill where they're on a ventilator or they're gonna die within a couple days of getting a transplant. You have to be like sick enough, but not too sick, if that makes sense. So these people tend to have some type of revelation that says, I'm done smoking, I gotta take my meds, I'm gonna get on the transplant list. So theoretically, you can get put on a list after you quit smoking for how long do you suspect? 6 months. That's a long time for someone who's been smoking for 30 years. So why do we say to a patient, sorry, you can't be on the transplant list if it's been a month? Why is a month not sufficient enough? High relapse, right? Because we all know people that quit smoking are very vulnerable, especially in that first couple of months. So once they get to 6 months, which they just have to have a number, you guys, there's no rhyme or reason about it, but they say 6 months. So what if at 5 months and 29 days they light up a cigarette? You just put yourself at the end of the list. Okay, so we have to make sure. How do we know? Are we gonna be in their home watching to see if they're smoking? Well, probably smell, but is that still enough? Because what if someone was smoking around them? No, we have lab tests for that. We can see if there's nicotine inside of your one. So that's why like insurances will say, let's get lab draw. So even if you say you don't smoke, they test for it anyway. And they'll know if you smoke or not. So nicotine can be found in blood. So easy enough. Then you have to make sure that they understand that the rest of their life they'll be on what kind of medications. Yeah, immunosuppressants, possibly corticosteroids, and it's forever. You're never getting off these meds because you have an artificial, somebody else's lung tissue inside of your lung. So this just came out, I think it was over Christmas break, I read this article. And again, I don't know why, but sometimes on Facebook it just comes up and like, it was legitimate. But these doctors have been working with pig hearts. You don't see this article? And they did their first, watch it was their second transplant in the last year. And they did a pig transplant to a live person. And what they did with this pig, because it's not just like, go pick an animal, yep, your heart looks good. They actually, what's the word here? When you like raise animals and you mate them the way you want them to and you like change their DNA, they literally do that. So they take a mom and dad pig and they can alter how the baby's gonna be based on their DNA, and they tried to match it with like a human. Isn't this amazing? So then the pig was born, they raised it to a part where the heart was the size of the adult they were gonna put it in, and this person who was now ready to be on the list and have the same thing, got the heart. And so I don't know if he's died yet, because the first one they had was last year, and he lived, I think it was 7 months. But still pretty successful. I mean, truthfully, you have a pig heart for 7 months, you bought yourself 7 months. And how much did that cost? Probably not compared to like a regular heart, or like some of the things with, you know, the ethical dilemma, and we have to have actually people that die to donate a heart. With pigs, you could raise 1,000 of them, I mean, theoretically, and take all their hearts, okay? So this person that had over Christmas break got a heart, so I don't know how he's doing, but they said it was way more successful. They changed some of their stuff from what they did before. So maybe it's the future. I don't know what's going to happen in the future, but maybe it's the future of we'll have pig hearts whenever our hearts will need it when we're 75, right? Theoretically, it could happen. I don't know what's going on here, but we're going to finish this. Okay. Also what we can do, so sometimes whenever there's not a transplant available, or you have a patient that maybe isn't doing the laws or the guidelines of what they're supposed to do, they can do lung reductions where they basically go in and they take out the alveoli that are doing nothing. They're basically just taking up space, and they might be taking away from good alveoli and kind of making that process harder. So they'll go in and they basically take out all the bad alveoli. So they kind of reduce the size of that lung. And it's going to hopefully help with the alveoli that are not so bad. What do you suspect is probably a high risk after doing any type of transplant surgery? So what are some risk factors that can happen after? Rejection, of course. Infection, huge. There's a couple more. With any really heart transplant, lung transplant, kidney, it's gonna be coagulation. Like, are you clotting or bleeding, right? Because you just manipulated a lot of the major vessels, and there can be some bleeding going on from trauma. Maybe you nicked an artery while you were in there, or you caused an inflammatory state where it caused a clot. That could happen too. So they are very high-risk surgeries. Here's the 2-year survival rate of a transplant. So pretty good. These people are happy to get 1 year because with the alternative is 0 years. So consider that these people might be 65, and if they could get 5 years out of a transplant, it's gonna be worth it to them. So even though you may think, well, geez, that's not very long, it is to someone that wants more time, okay? So 5 years is better than no years. Okay, again, there's meds at the bottom. We're gonna talk about this with asthma today. But when we are looking at people that have COPD, we are trying to always prevent infection. They have a huge risk for infection, lung infection, I should say, because their lungs do not pump the way they're supposed to, and they are not gonna have as good defense mechanism to ward off a simple cold. So they tend to get pneumonia, upper respiratory infections, way more than the average. So what vaccines would we recommend for this population? I did mention the two. One is the first one you get every single year in the fall. Flu, so influenza, that's a yearly. And pneumonia, right, is the next one. If you're 55 years old, not quite 65, can you get the pneumonia vaccine? Yes. So people that are high risk, that typically we wait till 65 to give the pneumonia vaccine, because mostly people in this room, you're not gonna die of pneumonia, okay? You're young, you're healthy, you don't need to. But what if you're 45, you have really bad COPD, and you smoke? You should probably get the pneumonia vaccine if you're high risk. So those people will be encouraged to get pneumonia vaccine every 10 years if they're younger than 65. What about over 65? Their first time. Just one time. That's all they needed, okay? What's the rationale there? Most people probably not on their 65th birthday are coming in to get their pneumonia vaccine, right? So they're like, oh, turn 65 today, better go get my pneumonia vaccine. Okay, it might be 68, 69, 71 when they truthfully get their first one, and most of the time by the time they get to be 80, they really don't need another one, okay? They can if they make it that long, but they really only need one. Okay, so these meds we'll talk about. We'll talk briefly about cultures. So what's the point of getting a sputum, blood, urine culture? What does a culture show us? Specific pathogen, okay? Because people that are immunocompromised or people that have COPD, they might pick up like a viral pneumonia, bacterial, fungal, just something that isn't the typical where you need antibiotics. But sometimes you'll be able to identify which one so they don't get resistance to some of the antibiotics that we give. So COPD patients, they've actually had guidelines that come out that they have been starting COPD patients on a very low dose antibiotic indefinitely. So instead of getting pneumonia 3 times a year, which some people do, they put them on this low dose antibiotic that really gets the most primary pathogens of pneumonia, and they take it every single day. What is a risk factor of that? Resistance, right? Now, what's the alternative? They die of pneumonia. So you have to consider the pros versus cons here. But they usually will put them on like a Z-Pack. We have Z-Packs for like a couple days. They get like a zithromycin every single day, and that's what they get, okay? One time I was talking to, I followed this guy out here at Grasslands, and he was like, well, I'm kind of an older nurse practitioner, and I didn't believe in putting antibiotics on someone every single day. And I met this 90-year-old woman with COPD. She was on Zithromax, like a 250 milligram dose, which is small, every day, and she's been on it for like a year. And she was a new patient of mine, so I took her off of it because I thought it was stupid to put her on antibiotic every day. The next week she got pneumonia. And she didn't die, but he was just like, yeah, I've started the zithromycin again, I never touched it again. Okay, so there is some truth to what it does, and you have to consider the alternative too. So, pretty good med there. So again, we'll talk about these meds with asthma today too, in more detail. Okay, we talked about oxygen. Just remember respiratory drive. I would know how to define respiratory drive. Like, what does that mean? And what does it mean to have oxygen in excess on a patient with COPD? What if it's short term? Because sometimes when we suction patients, which we'll talk about suctioning next week, but before we suction someone's airway, we will give them, we'll call it hyperoxygenation. We'll give them like a mask on the face for a couple minutes before we give a deep suctioning. Is that okay in COPD? Yes, it's short term. When we talk about excessive oxygen, we're talking at home where they bump their oxygen up to 6 liters and they leave it there for 2 days. Short term in the hospital, if you come to the ED and a COPD patient stats are in the 60s, you're not gonna say, sorry sir, we can't give you oxygen because you're a COPD patient. That's not gonna happen, right? It's something more long term that we start to worry about having the excessive oxygenation. So short term's okay.
Positioning.
Sorry, so for like someone at home with oxygen, like would they get sent home with a tank or something that can only get put up to 4 liters, or do they?
No, because if they are truly at home, and let's say they do, it's kind of a safety thing too. So of course we want to educate them on what they should be doing. But what if they did like get up and they're moving around and they really did need 6 liters for 10, 15 minutes and then they put it back down to 2? Because they won't be able to go more than 6 because they get a nasal cannula. So at least that's good, they're not getting 15 on a mask. They do not get masks at home unless it's a special case where they listen and they are coherent. But 6 is the max they'll get. So, and 6 liters on someone's body is gonna take probably a couple days to a couple weeks for it to do that. So it'd be a patient that's really abusing the system, essentially. Okay, positioning. We talked a lot about positioning with COVID, okay? What do we do to COVID patients in an ICU when they're on a ventilator with positioning? What's it called?
Prone.
What?
Prone.
No? Prone, I hear it. Proning. What does proning mean? Face down, so they're literally on the bed like this. The ventilator's coming out, they're not typically where they're on their back, okay? So why do we prone people? It doesn't matter if it's COPD, doesn't matter if it's COVID, doesn't matter. Because think about gravity, okay? So gravity with the secretions, the bacteria, typically are gonna go to your bases, or if you're on your back, which is typically where we always are, right? We're always laying on our back or laying on that part in the hospital. So for parts of the day, instead of laying on your back all day, they go onto the front and moves to the front. So it just kind of moves that bacteria out of the lung. So let's say you have pneumonia, and it's a left-sided pneumonia. So you have a left lung here. This is the bad lung. This is the good lung. How would you position your patient? Or try to, at least. Would it be lay on our right side, or would it be lay on our left side? We lay on our right side. Why do we do that? So if I'm laying laterally with my right side, my left lung, who is right here, it's gonna move more towards the bronchus so they can cough up the bad, okay? Or they can move that secretions out of there. So if you have a bad left lung or a bad right lung, you lay on the opposite side to make the secretions move. Because what would happen if I had left pneumonia and I laid on my left side? It's just gonna pool, right? The bad is just gonna pool there, and my right lung's just up here going, I'm good. Right? I don't have to do anything. So always position people with good lung down. You ever hear that? Good, no, excuse me, good lung up. Good lung is up, not a line. Good lung down, there you go. Bad lung is gonna go up, there you go. Which should make sense. Gravity does a lot. That's why people that have breathing issues, we tend to, when we're laying down flat, you have to kind of work against gravity. So if you sit up, it's not as hard to breathe. All right, percussion. Did I demonstrate percussion on anyone here? So percussion is going to be kind of like just the tapping of the chest. Cystic fibrosis patients, they have that vibration chest, or it literally vibrates their chest, and then that's going to help remove secretions. What med could help here? With secretions that you just can't get up. Expectorants, right? So guaifenesin. Couple things on guaifenesin. Drink 2 to 3 liters of water. That's pretty much the standard. Can pregnant people get guaifenesin? The answer is no. It's category D, which Paige informed me that categories don't exist anymore, but it still tells you, I like the note letters because it tells me is it bad or good. So probably not recommended with people with pregnancy. Okay, we're gonna end there with COPD. We're gonna move to asthma. But the biggest thing with asthma is that you're gonna see a lot of similarities, okay? But remember on the test, when it comes to meds, pretty much the same for meds, but the kind of the pathophysiologies behind asthma COPD are a little different. But you could probably argue and say, asthma and COPD both have the same risk factors. They have some genetic predisposition. They look very similar on assessment, and the meds are the same. So that is kind of nice that they overlap a little bit. Okay, so of course you can read, but if you were to think of key words, and if someone asked you, let's say a new nurse, because remember we're talking to a new nurse, not a family. But if you were to say, what is asthma? What words come to your brain? Not symptoms, but like pathophys. What is going on in the lungs with asthma? Okay, so bronchoconstriction. Is this bronchoconstriction consistent or constant? If that's the case, everybody with asthma would be walking around wheezing all the time. Is that really true? No. Why does the bronchoconstriction occur? Triggers, right? Everybody has different triggers. That's why some people with asthma, some can be around or can't be around like hay in the fall, right? Or that kind of stuff in the air. Some can't be around animals. Some can't be around smoke. Okay, there's different kind of triggers. I heard another one over here that someone said. Perfect. Inflammation. It's an inflammatory problem. So if you hear the word inflammatory, think of itis. Any type of inflammation in the body is going to end with itis. So if you hear itis, I think of red, swollen, and full of mucus. Okay, just because if you think about your toe, if it becomes inflamed, we all know if we stub our toe, it's red, painful, it's swollen, and if I puncture it a little bit, it's probably draining. Okay, so inflammatory is going to refer to the lungs inside of there. The bronchoconstriction on top of the inflammation is what's going to cause the person to potentially go into anaphylactic shock. Does every person that has asthma go into anaphylactic shock? No. It'd have to take a pretty bad trigger and no availability of medications. So that's why they carry around their little inhaler, right? Their albuterol, and it's a temporary drug where they might potentially say, you know, my trigger is exercise. So I'm going to do my albuterol inhaler 15 minutes before exercise, and then I'll be fine. Or maybe they're inside of class and someone's perfume, they're right next to someone, they didn't know that they were going to wear perfume today. And they sat next to them and they're like, oh my gosh, I'm getting like shortness of breath and wheezy. They pull out their albuterol and they treat it as it's happening, okay? So these kind of things only happen when they have their trigger. Let's say they had the perfume exposure, or let's say someone brought peanuts that were in these candy bars from this morning, and they could potentially go into anaphylactic shock if that was kind of their allergy or their asthma, okay? Asthma and allergies are heavily tied together. If a kid has a lot of allergies, they have a high risk for obtaining a diagnosis of asthma in their lifetime. Pretty high chance, okay? So it's intermittent, but it's chronic. So you have the issue forever, essentially, but it happens intermittently. So if you control your triggers or prevent them from happening at all and take your medicines, theoretically, could you never go into an asthma attack? Yes, okay? Now could you say the same thing about COPD? No, there's this chronic progressive. It gets worse, 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 worse until they die. Asthma, it's chronic, they're gonna have it forever, but they have these times of good, bad, but their good could last a long time if they control the prevention of it. Asthma, and can you grow out of it? A lot of times people say, well, I grew out of my asthma. What happened with that? About 1/3 of people will grow out of their asthma. Remember the airway that I drew for you? So if this is baby, and this is an adult, what did I say was the adult or the infant or baby's airway? 4 millimeters across. An adult was 20. Okay? So the diameter of their airway, their trachea, increased. So even though they have asthma, there's a bigger hole, so there's not as much mucus to get plugged up, or bronchoconstriction maybe isn't as bad because they have a bigger airway now. Okay? So consider that the adult person might potentially not have the symptoms, but do they still potentially have the risk of getting exposure triggers that could cause issues? Yes. As a baby, they might have had wheeziness, who knows, even anaphylactic shock, but as adult, now they have seasonal allergies, or they just kind of have like some runny nose, a little bit of scratchy throat, and it happens maybe in the fall or the spring, whatever time is your trigger time, okay? You grow out of it in the sense that you might have symptoms, but you still have a diagnosis of asthma. So if you were diagnosed as a child with asthma, you still have asthma, you just haven't had a trigger or an episode for years. Some people say, I haven't had episodes since 6 years old, and now I'm 25, okay? They might not even carry an inhaler around. So some of you in this room might be asthmatics, or sophomores, or a couple examples of some. One had an inhaler because hers was worse. The other one says, I do have asthma, but I haven't had an episode since high school, so I really don't carry my inhaler around, okay? So her risk is probably pretty mild or low. So she knows that if she gets exposed, she might have some irritants, but not enough to like kill her, right? So it's probably just more mild. Okay, so this is what's gonna look like when you get your trigger. The pathophys behind wheezing is that you're going to have either bronchoconstriction and inflammation that develops in here. Bronchoconstriction is actually the smooth muscle that's in the bronchial tubes. It's not the mucus itself, okay? The inflammation is like the mast cells, the white blood cells, neutrophils, whatever's coming to the source of the lungs, that is where you have inflammation. They're different things, okay? So, let's talk about wheezing for a second. If I have a hole this big, and it's trying to get through, and let's just say this is all mucus, okay? You're gonna get wheezing on assessment. You can hear that with your stethoscope. But what if you have a patient that you're listening to their lungs, and they've been wheezing for the past hour? You hear it, okay? And maybe we haven't given really anything for drugs. And all of a sudden, you stop hearing wheezing, or you don't really hear lung sounds at all. What do you think's going on? So the wheezing stopped, it must be good, right? No, you completely probably got to a point where there is no air into that area, okay? So if wheezing abruptly stops, wheezing will not magically go from wheezing to nothing. Wheezing will slowly get better over time, even if they took drugs or medications. The wheezing takes like hours to resolve. You'll even hear those people that, you'll have really bad wheezing where you can hear them from the door. We all know they're wheezing. But then at like 6 o'clock at night the next night, they kind of still have a little bit in their bases, right? There's still some wheezing there, it's just not as crazy high. So if wheezing stops abruptly, that's a sign of occlusion. There is completely blockage of that airway. It is a medical emergency. That's what happens to people in anaphylactic shock. So if that happens, wheezing stops, there is no air. There's no airway. Bad, bad thing. Okay, talked a little bit about this, but we're not gonna talk about the airway much anymore. Now I wanna talk about the ribs, okay? So, do I have a picture on here? No, but I'm going to. I think it's on your RSV PowerPoint, but I'm gonna bring that picture up. It's a really good picture to show retractions. So retractions are kind of unusual because adults usually don't have retractions, but if they do, that person's actually really struggling to breathe because that means that it's so bad that it's affecting their lungs. Oh shoot, I have it on there. I know the picture I'm thinking of. This won't work. Okay. I want to be able to see the words. Okay, there you go. Okay, so if this is your kid and you have retractions, the higher up the retractions means that more of the lungs are affected. It usually starts in the base and works its way up. So if you have suprasternal, so supra means above, and it's above your sternum, or even supraclavicle, above your clavicle, is that worse or better than subcostal? Think of the location. It's worse. So is the person doing worse? Yes. So on your test, I'm gonna have different landmarks. This is the hot spot. You have to know the different locations, because if I say the kid has intercostal retractions, point to me where intercostal is. So inter means between, and costal referring to inside those ribs there. Okay? If you have clavicular or subclavicular or supraclavicular, you're gonna have them above the clavicle region, which should make sense to most of you. But I would know the landmarks of where retractions are and what it means to have high retractions. That's a really sick kid. If a kid has suprasternal, what else would they look like? They're not just gonna have retractions, guys. There's gonna be other signs. At that point, they're probably having like cyanosis, nasal flaring, that grunt, okay, that I was telling you about. Listlessness, where they're not playing, they're just kind of limp, okay? Babies especially, like a little month-old baby, they're kind of flexed, right? No 1 month baby, unless they're sleeping, are like limp. If they're awake and they're limp, that's a very bad sign, okay? They're kind of contracted, and and their hands are like this. They're flexed. That's a good sign that babies are healthy, okay? When a baby comes out of the wound, what does a baby usually look like? Okay? Pink is a good term, but remember, not every baby's Caucasian, okay? So what about Asian babies? What do they look like when they come out? Anyone ever seen an Asian baby delivered? Do you know? Do you know what they look like? Well, I know that. Yeah, we're gonna have tomorrow, but seriously, I'm talking like Chinese babies. I shouldn't say Asian, because that can mean a lot of different ethnicities. But Asian babies, specifically Chinese, are blue. They are blue, you guys. Ask Renee Schroeder. She was a surrogate for a Chinese baby. Did you guys know that? So she's a surrogate. She knew it was Chinese. When it came out, it was completely blue, and she didn't tell the doctor the baby was Chinese. The doctor assumed it was a white baby. Baby came out, and Asians don't look drastically Asian when they come out, right? They look just like everybody else. Everyone's the same look as Caucasian, everyone's the same. Even black babies, they're like white, you guys. They're not this black baby, okay? They can be white in color. So when they came out, the Asian baby was blue. And the doctor freaked out because she or he thought that it was cyanotic, and then they looked and they're like, oh, it's a Chinese baby. You should have told me that. Because they come out a little more blue color, okay? So the very first time a baby comes out, no matter if they're Caucasian, black, whatever, they kind of have sometimes some blue tint to them, okay? So Asian babies are worse, or even Chinese babies are worse. African American babies can even look pale in color, and Caucasians have like a blue tint to them. Does anyone know what the term is called? Starts with an A. You learned it in health assessment, I bet. Sometimes they'll call it cyanosis. I can't spell cyanosis. Primary, because they know it's just related to birth. But I'm talking the first 24 hours. Acrocyanosis is meaning they have that blue color to them. It goes away within the first day, okay? Now, does every baby come out blue? No. But if you see that in the first 24 hours or even couple hours, they kind of have blue their tips of their fingers are blue. What else would you do in that first couple hours besides just look at skin color? Look at O2 sats, right? Look at if they're having retractions. Are they shortness of breath? This alone, blue fingertips, is not enough to say they're cyanotic. Now look at the word inside of this word. Cyanosis, right? Blue. But the acro was referring to, it's not a severe thing. It's something that just happens with some babies at birth. But yeah, so Renee, being the person that she is, she goes, well, I didn't care that the baby was Chinese. It had nothing to do with it. And she's like, and the doctor's like, it does for when you're having a baby that they present a little differently, and I need to know that. That'd be something I need to know. So at first when it came out, she was like, oh no, it looks blue, and she goes, oh no, it's Chinese. Like, can you imagine the dynamic in the birthing room? Like, no, it's fine. So I thought that was kind of funny. Well, and I knew Renee long before she worked here. And actually, she was pregnant with, when I was pregnant with Holder at the same time. So during my visits, she was pregnant, I was pregnant. And I was like, oh yeah, how's it going? I read her blogs, and like I was ready for her to have this baby. And then I saw pictures, and I was like, oh, didn't tell me it was different ethnicity than you. And she's like, well, it didn't matter. I'm like, I know that, I just wasn't expecting that. It's kind of cool. You have that kind of issue. All right, sorry, moving on. Okay, so risk factors, here's all your triggers. So one thing I'll probably encourage you to do for this test is know where triggers can be identified, and you're gonna have to deal with some very awkward situations. So I'm gonna give you an example. You have an asthmatic kid that comes in for the 4th or 3rd time this year, and their parents are smokers. That's a hard one, isn't it? Because the kid can't control his home setting. He can't, I mean, yeah, he can tell mom, I really want you to stop smoking, but if they don't stop, is this gonna go away? It's not gonna go away. So there's some ethical issues with talking to a parent about smoking. So what do we do as nursing professionals, the doctor should too, if a parent is smoking and the child is having frequent hospitalizations? Does the parents know? And I'm not trying to say the parents aren't intelligent, but sometimes they don't put the correlation together that they're causing this issue, okay? I'm gonna bring up my parents-in-laws because I love them dearly, but they smoked in their house forever, and it was terrible, okay? And the oldest son, so my husband is one of 2, there's 2 boys. The oldest son has asthma, really bad asthma, had his whole life, and I don't think the parents ever truly understood that the smoking component was a part of this. And so they kept smoking in the house. And he would have asthma attacks like once a week. And he had this inhaler, they're so, but you're putting a trigger in their house now all the time, and you're watching your kids suffer because they're smoking in the house. Like, just thinking about some of those ethical dilemmas. And I think when he grew up, he went to college and got smarter and realized the smoke obviously was an issue. And one time he came home from college, it was like, I think we were like in high school, and he was like 22 or something. And he came home and the mom was smoking, and he was coughing, because coughing is a very high sign of asthma, trouble breathing. And she's like, oh gosh, why are you coughing so much? You're like, you getting sick? And he goes, no, it's the fucking smoke. And that's what he said directly to her face. And me and Toby looked at each other, we're like, well, this is happening. But seriously though, it is true. Like, I think he realized, like, you did this to me, right? And again, I love my parents-in-law fine, but those are things that I don't think she realized that they were doing that, okay? So always remember in the hospital, parents don't know sometimes, you guys. Like, you have to educate them. Sorry, I didn't need the answer, that's what he said. You know, I just remember like, oh, okay, hold on there. Other things, I think seasonal is a big one. So outside is a huge trigger for a lot of asthmatics. Think about if you had a farm kid and they got asthmatic and they needed help on the farm. That's a big problem, right? You can't just tell your dad or mom to change their jobs. Or you can't just say, Mom, we have to move off the farm because I have asthma. So there's some things that can be physically changed. Yes, you physically can move in town and your parents could quit their job, but truthfully, is that gonna happen? No, okay? In the hospital, if they bring some type of toy, what do we encourage toys to be with asthma patients? Non-like clothy type things, like teddy bears, blankets, which this is hard too because a lot of kids like their blankets. But if they're having an asthma exacerbation and their blanket reeks of smoke, or like the pet, maybe they sleep with their dog at night, okay, this is gonna cause more issues. So try to have more appropriate things that you can easily wipe off. So possibly like some type of plastic toy, coloring books are okay, iPads, sadly enough. Where's my iPad? Over there. iPads are great for the hospital because they can distract kids. TV is okay, but try to stay away from the clothy stuff because that's gonna cause more issues. Now, are they gonna go home and take that home with them and have it happen again? Yes. But for the hospital, it's on your dime. At home, it's on parents' dime. Okay, so I don't mean to be like, push the problem on them, but you don't want them to have asthma attacks in the hospital. Okay, and then last, I'm just gonna kind of talk about some of the infections. So a kid that has asthma, and the reason I say kids, you guys, is because primarily this is who has the most problems with it. You can have asthma as an adult, but kids who are asthmatics, they don't have the autonomy or the knowledge to like say, I'm gonna avoid my triggers, right? Like my son is very allergic to hay, well, to the point where he gets wheezy, and guess what, every fall, he wants to go to the pumpkin festival. It's kind of like a, oh, I hate the pumpkin festival because he loves it, but he knows that he doesn't realize that he's gonna have breathing issues after. So they don't really get that concept. But infections, kids that have asthma are 50% more likely to get all the respiratory junk. So when there's a respiratory cold going around, croup, RSV, they have way more high chance than a kid that doesn't have asthma. They just don't have the tissue, the good lungs that they normally would have. Okay? Another thing too, a kid that frequently spits up as a baby. Okay, I want you to think critically about this. If you have a baby that pukes a lot, GERD, babies can have GERD, where they puke up their milk all the time. Why do they have a higher chance of getting asthma? Aspiration, I heard it. I don't know who said it. Taylor. Okay, so if a baby pukes in the night, they're on their back, what's gonna happen? Right? They puke, it goes back to their mouth, or sometimes they swallow it, and we all know that our stomachs are very acidic, right? So when you vomit up, you can even smell sometimes baby vomit is very acidic. I know it's kind of like pretty obvious, like, right, Max? You know that, right? You've been puked on by baby, maybe? No, I'm just kidding. But when you get puked on, it's very acidic. So if they aspirate and that acid goes into their lungs, what happens to lung tissue? It starts to deteriorate, right? Or it hurts the lungs. So they get asthma, or they have a higher chance of asthma because they have aspiration from their vomiting as a kid, or they're spitting up, okay? There's a lot of research that shows that. Okay, so we'll end there. And then my plan on Monday is to finish asthma. I'm gonna look at the meds a little bit. We're gonna talk about the needs to know for meds. And then we'll see what we can get through on RSV. That'll be our main